My name is Hannah Zaidi. I am a member of the Paul Torrens Health Forum Planning Committee. So on behalf of the UCLA Fielding School of Public Health and the UCLA Paul Torrens Health Forum, thank you everybody for joining us this evening. More importantly, we know it's a Wednesday and there's lots of traffic, so we are very appreciative of people coming down to the West Side to participate. So thank you to everyone in our audience. This event is currently being live streamed, so thank you to our live stream audience as well. To get this event started, I am very much excited about tonight's topic. I think for many of us as healthcare professionals, we're very much reminded about the impact of homelessness on our healthcare delivery systems and the programs that we operate. But I think more importantly, as community members and as residents of LA County, we are very much reminded of the impacts of homelessness in our personal lives and in our communities. So I'm very hopeful that tonight's discussion with our very experienced moderator and panelists will provide some context and insight into how we can address this issue, both in our professional lives and in our personal lives. So this event is named in honor of Dr. Paul Torrens, a beloved professor emeritus of health policy and management at the UCLA Fielding School of Public Health. Dr. Torrens has had over 40 years of experience and mentorship, patiently guiding students through career decisions, and really helping to shape their careers. One of his visions was to develop a community forum to really talk about critical issues that impact public health. And so because of that, we are here today. This speaker series is inspired by Dr. Paul Torrens and now bears his name. So one housekeeping item, so for everyone in our in-person audience, please silence your devices in respect to our panelists and our moderators. So to get this evening started, I would like to introduce our moderator, Dr. Randall Kuhn. He is an associate professor in the Department of Community Health Sciences. He is a demographer and a sociologist focused on the social determinants of health and homelessness. Dr. Kuhn was director of the Global Health Affairs program at the University of Denver. He founded the Goal 18 campaign for inclusive UN Sustainable Development Goals, and co-founded the UCLA Transdisciplinary Homelessness Research Initiative. So we are very honored to have him today to be our moderator. Dr. Kuhn.
Sorry, this microphone's a little low. Thank you, Hannah. It's a pleasure to be here. Thank you to the organizing committee, to Alina Dorian, to Yael Apt, and to all of you who have chosen to shine a much-needed light on the issue of homelessness. I tell people it's very hard to get people out for a talk on homelessness around here, but when we do, they're incredibly enthusiastic. And so we all need to keep up the great work and spread the word. I just wanted to start briefly, I hope, by framing what we mean by housing is health, the title of our forum. And I'll just note that originally when we were planning this forum, I threw out the idea of, we talked about the notion of housing as health. It's a little more academic than housing is health. I actually was suggesting maybe it should be housing as a driver of health or something like that, which is why they don't leave me in charge of planning these kinds of events, because people are actually here, which is great. So now that we've got you here, I can get as wonky as I want. In the late 1990s, I had the privilege of working with Professor Dennis Culhane, a pioneer in the field of homelessness, on developing a typology of homeless services clients. we used individual shelter utilization profile data from what was then a fairly novel class of homeless management information systems, HMIS databases, that are now the standard for how we measure homeless care and coverage. And we were working to identify unique clusters of chronic, episodic, and transitionally homeless populations in New York and Philadelphia. In Philadelphia, and these are the data just from Philadelphia, in Philadelphia, the transitional group, you'll see, accounted for 73% of the homeless shelter client base. And yet, because they were only homeless for on average of 20 days, they actually only accounted for 6%. So 73% of the population accounted for only 6% of the shelter days. By contrast, the chronically homeless group were just, that's the gray group, were just 10% of the homeless client base, and yet because they were in shelter an average of 253 shelter days over a 3-year period, they accounted for 79% of shelter days. So this is a kind of a textbook example of, you sort of have one group, all the people account for very little of the actual work, and a very small sliver of the client base actually accounts for most of the work. And these stark differences were reflected in the needs and the needs and burdens facing these different homeless populations, and pointed the way to a new vision for targeting homelessness. So the chronically homeless faced a far greater burden of mental illness, medical need, and substance abuse, as this graph shows, reflecting in large part the scars of years living in shelters. The services typically provided by emergency shelters, so housing placement, workforce training, a number of social protections, these services were simply no match for the extensive needs of this population, given the burdens that they faced. As a result of that, permanent supportive housing, or PSH programs, were developed to provide a foundation of long-term housing stability and recovery at a fraction of the cost of a shelter bed. For policymakers, these programs were a boon. So these are some results from the New York, one of the initial permanent supportive housing program evaluations, which basically shows that it cost $17,000 to put someone in permanent supportive housing, but you got more than $16,000 of those dollars back in averted averted shelter costs and healthcare costs, particularly emergency room and outpatient visits, which is that's one manifestation of what we mean when we say that housing is health. And yet, a number of studies, including the work of Suzanne Wenzel from University, am I allowed to say University of Southern California? That have demonstrated that for many high-burden, high-risk populations, like HIV/AIDS patients, housing is a start, but housing is not enough. That we need to start moving towards re-envisioning housing as a gateway towards a whole ecosystem of services that are person-centered yet scalable. And that is very much what all of our speakers are working on today. And so I look forward to hearing about that. Now we move back to the transitionally homeless population, who in our work had relatively low levels of disability. And if we could go all the way back to the initial homeless episode, one of the things we find in the homeless research literature is that at the moment someone becomes homeless, they don't look all that different from the average person in severe poverty. That one of the things we could say is homelessness equals poverty times bad luck. And so for a population that has recently entered homelessness, the real key is to get people rehoused as quickly as possible so that they don't become the chronically homeless and they don't become burdened by all of the consequences of homelessness. So rapid rehousing programs use a mix of subsidies and services to focus on getting people rehoused as quickly as possible, and have shown some success. So particularly in populations where there's a clear pot of money and a clear client base and a clear system. So in the Veterans Administration, they've used the Supportive Services for Veteran Families, or SSVF program, quite effectively for rapid rehousing, and this is one of our many success stories over the last couple of decades in homelessness, is reducing drastically, not nearly enough, the burden of veteran homelessness. Yet, even a few weeks of homelessness can have devastating repercussions. And so this graph shows that the population that is homelessness on any given night is really just the tip of the iceberg in comparison to an at-risk population. And so our own Tabanobari is working on researching all the many consequences of being precariously housed or in unstable housing. And these, so right, the consequences of housing for health begin well before someone becomes homelessness, and so programs have to begin. So rapid rehousing is increasingly becoming homelessness prevention. Our colleagues up at the California Policy Lab, Till Von Wachter and Janie Roundtree, are working with folks at LA County to use machine learning algorithms to identify households that are at risk of imminent homelessness and target a mix of services and subsidies, even small short-term subsidies, what we call shallow subsidies, aimed at preventing homelessness, right? And we know prevention is far better than a cure. So these are the challenges that are faced by every homeless care service, every continuum of care in homeless services. We need to increase the coverage and bandwidth of permanent supportive housing programs while also enhancing the coverage and the timeliness, the speed at which we can provide rehousing and prevention programs. That's already hard work. We've seen some success nationwide. In LA, of course, we have a couple other contexts, things in our context that are making this work harder. One, of course, is you may have noticed that we have a housing. Does anyone notice that? We have a housing shortage here, right? So, yeah, that's one. And then second, about 3/4 of the homeless population in Los Angeles, based on the point-in-time nightly count, are unsheltered. We are still in the earliest stages of turning these cases into clients, of integrating them into our coordinated entry system and integrating them into our continuum of care. That work is made more difficult, of course, and we have to think very creatively about how do we provide support and services to someone. If we say that housing is health, how can we provide services and support to someone knowing that they may not be sheltered or housed right away? That is hard work. It's work that I know many of you in the audience are already involved in, that many of our students are here to get involved in, give them all jobs. So I'm so thrilled to hear how each of our amazing speakers approaches these immense challenges. And with that, we will head right into our speakers. So each presenter will have 8 to 10 minutes to deliver their opening remarks. We will then have a moderated discussion followed by an audience Q&A. So without further ado, I'd like to introduce our first panelist. Their bios are in their programs, so I'll just briefly introduce each presenter. Marcia Temple is a lawyer, JD, executive director of the Integrated Recovery Network, and a UCLA alum as well. Welcome, Marcia Temple.